This presentation is about common ankle and foot problems. It's not comprehensive. It's just a little hip pocket training I do for my medics. Something I kind of pulled together from a bunch of different resources and presentations and things that I've been taught in the past. The main takeaway that I try to really enforce upon the medics is what's an emergency and what needs to be done now. And of course, that's depends on the conditions and where you're at, and if you're in a prolonged field care scenario, or if you're in just here on post or whatever stateside. But suspected fractures, those are urgent or emergent depending on the situation. Open fractures a little more serious and a little more. But I mean, any fracture other than pain, needs to be stabilized. And so, suspected dislocations, Lewis Frank injuries, you should look that up and read about it. A certain mechanism of injury that causes those, and it's a midfoot injury. It's pretty devastating. And then obvious emergency injuries, of course. But the mechanism of injury is very, very important for any kind of orthopedic injury. It's something you have to have kind of a spidey sense about, because and some experience helps, of course, to know what kinds of injuries cause what kinds of mechanisms cause what kinds of injury. So a fall from height, is something that it should cause you to have your spidey sense up. It should cause you to kind of wonder what else is going on. It should point you towards certain types of injuries. A trauma bay, civilian ER, I believe it's twice your height. Fall from twice the length of your height, how tall you are, is a reason to be suspicious for a traumatic injury and a trauma workup. So, things like that matter. And so, if you split wood, that's like a pylon. That's what a pylon fracture is. It's from the tibial plafon, which is from the bottom part or most distal part of your tibia. It's almost like when you land, you crack that up, like in the middle, like splitting wood. Sometimes you can't see that on x-ray. A lot of times you can't see it on x-ray, only on CT scan. So you have to have a suspicion about it. And then dislocations from traumatic force. But also a fall from height, you got to be suspicious of back pain causing a compression fracture from that axial loading. So spidey sense. Don't be afraid of x-ray. A lot of ankle rules. I use this all the time. It will make you not miss many fractures whatsoever, but it will cause you to x-ray a lot of people who don't have a fracture. That's okay, because the point is that you don't miss anything. And so you palpate both of the malleoli, which is the bony prominences on your ankle, the base of the fifth, and the navicular. No pain there. Plus, they can walk, about 4 steps or so without any, significant pain. They probably don't have a fracture. And so I use this according, MET-TC depends on what's going on. You're a little more lenient, but you won't miss anything. You won't miss a lot of fractures at all. It's a very sensitive test, just not very specific. These tests here, I won't go over all of them because you need to see them, you need to feel them, you need to do them. So it's another day, another time. But for like the squeeze test, looking for fractures, or the Thompson test, that's one that's really easy. Just squeezing the calf and seeing that the foot plantar flexes. And so you can watch a video about that too, but it's to make sure you don't have an Achilles tendon rupture. It's something not to forget about. Not everything is an ankle sprain. Sometimes you can tear that, or not tear, but you can have a rupture of the tendon. So close reduction principle is not talking about too much, but essentially you want to make things that are unstable stable, and you want to pad all bony prominences. You want to allow for swelling in the way that you splint something. You don't want to cause further problems. So splinting with fiberglass is good if you're in a clinic or a SAM splint out in the field, but wrapping something circumferentially. You want to keep that foot neutral, like dorsiflex a little bit. Don't want to splint somebody for a long time, like several days to a week, weeks, whatever, with his foot down, or he'll have a foot drop. He'll be tight, won't be able to pull it back up. Pad that bony prominence at the fibular head. You see the length of the splint goes all the way up to the fibular head, does not go above the knee, and so those are good splints. You don't want to lose reduction, but that's not really the point of this talk. You do want to minimize pressure on certain areas because you can get pressure necrosis and skin breakdown. And the point of the tight cast causing compartment syndrome, that whole point is just that, if you have something circumferential going around a leg or an arm, things like that, and you get swelling, you can cause an actual compartment syndrome from the pressure. And so a good key note is, Curlex. Some people put Curlex around an injury, which is fine to stop bleeding and good for gauze, but bad for when it starts swelling if you have a fracture or a deep soft tissue injury. So, you want to use Curlex to wrap back and forth, back and forth, back and forth as gauze, but not around a joint, around a extremity. You could have some problems with you can't pull Curlex apart. You can stretch ace bandage, you can stretch cast padding. You can't stretch that Curlex very well. So the whole point of this slide is covering that wound up initially drastically reduces open fracture infection rates. And so, two things for open fracture infection rates are covering the wound with sterile or saline gauze and getting antibiotics within 3 to 4 hours or so, IV antibiotics, usually NSAID or something more, depending on the type of wound you have and how dirty it is. And obviously your allergies that you might have. But so big thing, medic out in the field, open fracture, all the other emergency things notwithstanding, just taking a flush or taking a bottle of saline or whatever and putting it over gauze and then putting that over the wound and covering that open exposed bone or injury there, and then wrapping it up and covering it reduces the infection rate drastically. A lot of docs that I've worked for are getting away from betadine and peroxide because they feel like the hydrogen peroxide and betadine kills the good skin, kills the good tissues, like very traumatic, injuries that are not super dirty, of course, but super traumatic injuries. You're trying to fight for not just bone stabilization, but also wound stabilization and healing of the skin. So saline, we use maybe 3 liters, 6 liters, whatever, to flush out wounds. A lot of times and the OR, that's what they do. They just put up several bags, like several 3-liter bags of saline, and they have tubing, and they just irrigate. So that's a change. Transitioning to the last thing here that's common. Again, this is not comprehensive, but just things that we see a lot. It's plantar fasciitis. Soldiers have this a lot. And you can read all this about it. You can see the area of pain there it talks about, and that's just the bottom of the foot causing a lot of pain. First step down in the morning. You might feel that pain early, and it kind of gets better as the day goes on. Sometimes when they're walking on mats in the gym, it hurts a lot more, stuff like that. And the podiatrists say this may take 6 months or so to heal, really. So it's not an easy thing to fix. Some of the things that we do, the night splints that people wear, the frozen water bottles, they take the water bottle, throw it in the freezer, use it and roll it their foot along. It helps it with analgesia and helps with the reduction of the swelling and pain, things like that. NSAIDs, of course, like ibuprofen, naproxen, things like that. Steroid injection, some people are still doing that. A lot of podiatrists still do it, try to calm down the area. I use orthotics a lot to help people to try to give them support, like insoles, things like that. Surgery, of course, and then 10X is a new thing that people are using where they make a laceration or an incision into the bottom of the foot. They take a probe, which has ultrasound, and it goes straight to the tendon and try to beat it up a little bit and cause it to regenerate and heal. And there's some other things that people are doing in the same type of way to help do that. So, plantar fasciitis is really hard. I think for medics, you can give them NSAIDs, you can give them the orthotics, you can give them the ice bottle, you can give them, maybe there's like the foam roller or the vibrating foam rollers they have now, but it's really hard to really combat. This is a list of all the things that are common. This is a hip pocket training that I do a lot for medics, and hopefully this helped.